today with some doctors, nurses, AMPs, paramedics, social prescribers, health and wellbeing coaches, care coordinators. So that's really brilliant to see so many different roles. It's difficult to pitch a presentation for all of those roles. So if you have kind of questions that are different from what I'm presenting, then by all means ask. So just to flag the Grow Knots Primary Care app to find out about CPD in Nottinghamshire. And then obviously this is a session arranged by Nottingham Alliance Training Hub. Here are our communication channels. I'm not from NATH myself, but I've worked with them lots in the past. So I'll share some information about BSLM a bit later on as well. So that's my organisation. So today's learning objectives, we're going to look at why lifestyle medicine is needed in today's healthcare landscape, what we mean by it, try and identify where our own role sits, because depending on what our job is, we might have different perceptions of what our role might be within lifestyle medicine. And we're going to also talk about a couple of key skills for lifestyle medicine delivery. So the use of motivational interviewing and coaching skills. And if we have time at the end, we're going to apply it to some cases as well. But don't worry, I'm not going to get anyone to demonstrate motivational interviewing or anything like that. It will just be a case discussion. So non-communicable diseases such as cardiovascular and respiratory disease kill 41 million people each year, and that's about 71% of all deaths worldwide. Anyone care to shout out what percentage of deaths they think are attributable to non-communicable disease in the UK? It's 89%, so bigger than globally, and why this problem is so important, of the problem of non-communicable disease. So 98% of us live with a key behavioural risk factor for non-communicable disease, and most of these are modifiable. So things like smoking, heavy drinking, poor diet, being overweight or obese, or having low physical activity. And even those of us who may look after some of these elements, and we monitor our alcohol, and we don't smoke, and we try and eat healthily, maintain healthy weight, there's always other things that can be done to improve our risk profile. 60% of people live with 3 or more of these risk factors. So this graph demonstrates the number of years lost according to number of life years lost according to risk factors. So smoking at the top, as we might expect. High blood pressure, not necessarily itself a lifestyle factor, but heavily impacted by lifestyle. And just so when I first looked at this graph, I thought, oh, that's 1 year lost due to tobacco. That doesn't sound very much, but it's number of years life lost in millions globally. So suddenly it becomes much more significant. And then on the right here, you can see the association between poor health and demographic and socioeconomic factors. So this is sort of self-reported poor health. So generally, health perception of your own health gets worse as you get older. Males have a slightly worse self-reported health than females. Being married tends to cause better self-reported health compared to being single or separated. Those living in deprivation tend to report worse health, and also those with lower income, with it gradually reporting lower income in the lowest 20%. Education as well. So the lower level of education you have, the more likely you are to report poor health. So I mention all of these because the health inequality and the kind of social determinants of health are a key part of lifestyle medicine, because they have a massive impact on people's ability to follow a healthy lifestyle. So this is something patients want. In a study in 2017, they looked at how people wanted to manage their non-communicable diseases, and they, in general, preferred the idea of lifestyle over health. Often people want both. I'm a GP by background. I know, I might be trying to talk about lifestyle and the patient's just saying to me, well, can't you give me some medication so I don't have to do this, particularly around weight loss and these weight loss drugs that are coming out. I'm trying to talk about diet and exercise and they want to be referred for weight loss medication. So it's not universal, but lots and lots of patients do want lifestyle change. And so it's important that we have the skills and knowledge to give them high quality support around lifestyle. So I'm just going to close the door so nobody comes in, sorry. The defining lifestyle medicine then, it's not simply lifestyle advice. Lifestyle advice can increase in health inequality in unhealthy behaviours. There was supposed to be a picture on this slide. Oh, there we go. So essentially those with little control over their lives, so usually those living with high levels of deprivation and socioeconomic adversity, have more difficulty implementing lifestyle advice that is given. That might be because they have they don't have access to healthy food, either but financially or because they don't drive and they live in a neighbourhood where they don't have a supermarket, it's just all convenience stores. They don't have access to outdoor space for exercise. Many reasons why people might find it really difficult to follow the health advice that they're given. And what we see then is those people who had pretty good health already and are probably maybe living in a position of privilege are able to adopt this health advice that's given. People who are not so lucky in terms of their circumstances are not able to adopt the health advice because of the barriers I mentioned earlier and many more. And then you see that the gap in health inequality is increasing. Not recognising this is a really big problem and a reason, for the health inequality getting worse and worse. So what is lifestyle medicine then if it's not just lifestyle advice? Evidence-based clinical care that supports behaviour change, use of person-centred techniques to improve mental well-being, social connection, healthy eating, physical activity, sleep, and minimisation of harmful substances and behaviours. So that's what we refer to at the British Society of Lifestyle Medicine as the 6 pillars. And it can be used in prevention, treatment, and even reversal or remission of conditions such as diabetes or hypertension. It uses proven behavioural change techniques to support people in keeping with an awareness of their socioeconomic context. So we use the 3 principles of lifestyle medicine to define it, and that helps me remember everything that I should be doing when I'm thinking from a lifestyle medicine perspective. So acknowledge the need for action on the socioeconomic determinants of health, use of skills proven to support people to sustain lifestyle changes, and then the use of the 6 pillars that I mentioned earlier. So that's a useful framework to use when you're thinking about what kind of changes might someone want to make, what kind of aspect of their lifestyle might you want to be assessing and discussing with them. So taking that first principle then, I think probably we're all quite familiar with health inequality as a concept, but it's got a bidirectional relationship with a lot of these factors. So the wider determinants of health, some of which I've spoken about already, so level of income, whether they're employed or not, their housing quality, whether they have had a high level of education, access to natural and built environment, access to goods and services, and their power, and are they experiencing discrimination. There's then psychosocial factors around their networks and self-worth, self-esteem. These then influence health behaviours, so for example, smoking, diet or alcohol, and then those have the actual physiological impacts on the conditions, sort of non-communicable diseases such as blood pressure, cholesterol, anxiety or depression. The list could go on, of the things that are affected by all of those things. And this was quite an interesting study that looked at, so within cell biology, so this is a picture of a chromosome at the top, and these yellow bits at the end are what's called telomeres, and they're the kind of end bits of the chromosome, and how long they are reduces throughout life. So cells show that they're aging by having shorter and shorter telomeres at the end of the chromosomes. And what they found in this study was that if you have a low perceived neighbourhood quality, your telomeres get much shorter. So essentially, your perception of the quality of the neighbourhood that you live in can cause your cells to express cellular aging. So then moving on to the lifestyle medicine skills. So there's many of these. We can't cover them all today, but I'd wanted to just touch on them so you're aware of what we're talking about. There's first of all the principles of lifestyle medicine skills, which is person-centered care and values-based care, self-supported care. So that's a lot of personalized care type things. There's techniques used to deliver lifestyle medicine, so things like motivational interviewing, CBT, health coaching, brief interventions, goal setting, and lifestyle medicine prescriptions. And so lots of those kind of intersect with each other as well. Then there's how it might actually be delivered, so that might be through social prescribing and through group consultations or shared medical appointments, assessing people's level of activation, so that's sort of how empowered they feel, empowered and able they feel to take an active role in their health, and then use of tools. So the lifestyle screening tool, which I'll show you later, it's something that can be used. It's like a questionnaire that people can go through that asks about these 6 domains, 6 pillars of lifestyle medicine, so that you can get a very quick snapshot view of where their areas where they might be able to make gains are. So then going through the pillars of lifestyle medicine. So healthy eating is the first one, and that's really strongly affected by food insecurity. A really significant proportion of UK households are affected by food insecurity, which is basically when you're unable to so I don't have a definition of food insecurity on this slide, but it's sort of when you experience difficulty in being able to feed yourself or your family due to the financial or sometimes kind of logistical aspects of being able to get food. And it might be that you have very mild food insecurity, so it's stressful, you worry about it, and it's taking up mental load in your brain, thinking about how am I going to afford to put food on the table tonight and that kind of thing. It could be that you're experiencing very severe food insecurity, and that's when you get sort of people actually not eating, people in starvation. So food and vegetable consumption is much lower than we'd like it to be. So there's 48% of adolescents don't eat any fruit or vegetables, and 2/3 of the UK adolescents' total energy intake was found to be from ultra-processed foods. So this is things that even if you aren't necessarily experiencing food insecurity, and you might still be making sort of less healthy choices, and this is very prevalent in the UK. So this is what I was kind of going through before. So all the way through from worrying about obtaining food through to actually experiencing hunger and not being able to put food on the table. So advice around healthy eating is to base your diet mainly around multicolored plants. That doesn't mean that you have to all be vegans. It's just to say that they should really be a central aspect of your diet and meat a second kind of thought, rather than having the meat as the main thing and then the veg as like a may or may not have that on the plate. Reducing ultra processed foods. So there's a really big difference between, for example, a steak and some really processed burger that you've got from the frozen food section of your local convenience store, and they have different impacts. So people say, oh, meat is bad, or you cut down on meat, and in terms of health outcomes, that is, and that's kind of only part of the story, and sort of lean and unprocessed meat can definitely form part of a healthy diet, but ultra processed foods in general are less healthy. That said, there are some foods that might count as ultra processed that, you know, if you think about, for example, a tin of beans, that's gone through a certain level of processing. So we might be thinking, oh, that's a processed food, but actually that is quite healthy. So you do have to be able to apply a certain level of common sense to this. But in general, if something's gone through lots of processing, has a massive ingredient list, you can't remember, you can't recognise some of the ingredients on the list, then that's maybe a food to avoid. And we try and suggest people crowd out those foods with lots of healthy fruit and vegetables. So rather than saying, avoid this fruit, don't have that, we say, increase your number of fruits and vegetables and the diversity of your fruits and vegetables, and that tends to naturally crowd out the things that we don't necessarily want within our diet as much of. Teaching people skills to follow maintaining healthier eating patterns and choosing within their own circumstances. So having a discussion with someone about what their particular barriers to healthy eating are, and kind of exploring those and supporting them to come up with strategies for those. So different people will have different barriers. Different people will be at a different place in their diet or with their diet. So, for example, someone might be currently not eating any fruit and veg at all, and then for that person, discussing that increasing one or two, adding in 1 or 2 fruits or vegetables per day is actually a really good goal for them. Because if you say to them, oh, you need to be eating 5 fruit and veg a day, then they're probably going to find that quite unmanageable if they're currently not eating any at all, and may just completely ignore the advice. Or whereas if you're kind of having a discussion with them, what do you think you could do, what would be achievable for you, and they might say, well, I could have fruit each morning, and if they can get to that, then you've gone from 0 to 1, which is obviously a really big gain. And then you can go for, I'm not saying that we wouldn't ultimately aim for eating more fruit and veg than that, but adding it in slowly and building it up at a pace that meets, that that is suitable for them. Physical activity then. So we know, one thing I would say about physical activity is whenever I talk to patients about healthy weight, they say, oh yes, I've joined a gym. Physical activity is not necessarily that good for weight loss, but it is brilliant for general health, for feeling good, for increasing energy. It's good for weight maintenance, and at any given weight, someone's diabetic indicators, someone's blood pressure, someone's cholesterol level are likely to be much better if they're doing regular physical activity rather than being someone who's sedentary. So it's absolutely brilliant for your health. But if the primary goal is weight loss, then people shouldn't kid themselves that that exercise is going to be the predominant thing. You need to look at your diet as well in that context. The reason I say this is because I've seen a lot of people who have been really demotivated. They've been really dedicated with their going to the gym, but what they wanted was to lose weight, and they haven't lost that much weight, and they're feeling kind of really annoyed about that. Whereas if they had more kind of realistic goals about what they could expect from physical activity, feeling better, having more energy, improved of those, those blood tests, those parameters I mentioned earlier, then they might feel less put off by the fact that they haven't lost weight. So physical activity levels are not as high as we like in the UK. So 30% of children surveyed are doing less than 30 minutes of physical activity a day. And people who are in routine or semi-routine jobs are most likely to be inactive. Within physical activity, there's the concept of doing physical activity and also reducing being sedentary. So even if you can't go to the gym and do exercise, make sure that you reduce your sedentary time. So I work in a general practice, that might include things like going up to get my patient from the waiting room rather than using a call button. If I've got to go and speak to someone in reception, I will not just pick up the phone and ring them. I'll walk through to reception and talk to them. That's not going to increase my calorie burn in the day by very much, and it's not going to do much for my weight, but it will reduce how long I spend sitting in one place, and that's much better for, you know, my musculoskeletal health and just generally your metabolic health than to be sitting constantly. So supporting people to incorporate more movement and physical activity into their lives, and that can be really important when you're having conversations as well, because sometimes people feel it's really unmanageable to be able to go to the gym twice or 3 times a week. That's just something I can't fit into my life. But if you say, can you, you know, in their equivalent job, can you walk to see your colleague to speak to them rather than picking up the phone or something like that? Can you walk to the shop that you need when you're going to need to go and get milk rather than driving? All of those things might feel a bit more achievable, and it's reducing their sedentary time. So identifying and removing barriers to physical activity rather than maintaining their levels. So trying to think of an example for that. I'll come back to it. I'll need to keep going with our information. So these are the Chief Medical Officer's guidelines around physical activity. So we advise 150 minutes of moderate intensity physical activity per week. So when the way to identify moderate intensity physical activity is that you're able to talk whilst doing it. So that might be something like swimming if you aren't underwater, brisk walk or a cycle. You can imagine you'd be able to talk during that. Whereas intense, vigorous intensity physical activity is something that you would have difficulty talking whilst doing it. So that might be going for a run or playing a particular sport. So if you're doing vigorous intensity, you can do the recommendation is 75 minutes. You can do more than those levels, but that's the kind of level at which we see going from 0 to those levels is where we see the biggest gain. Increasing physical activity further does increase health further, but you get only very small incremental increases after that compared to the massive increase you say going from 0 to 150. But everything you can do is important. So like I said with the fruit and vegetables, if someone's not doing anything at all, asking them to do 150 minutes might seem really unachievable and they might just disengage. If they could even incorporate 5 minutes a day of some sort of physical activity, going from 0 to those 25 minutes would make a really big difference to their health, and that's something to build on in the future. There's different types of physical activity, so as well as these cardiovascular minutes that we're talking about, it's advisable to do strength training on 2 days a week, which might be functional things like carrying heavy bags, or it might be done in a gym, or something like yoga can be strength improving as well. Then for the older adults, it's important that they improve their balance as well. So that could be through something like Tai Chi, dance, bowls. So lots of these can be quite social activities as well. So that's another of the pillars. Alongside all of this, minimising sedentary time. So I might sit in my clinic all day looking at my computer and then go to the gym at the end of the day and do 45 minutes and think, oh, brilliant, I've done 45 of my vigorous intensity minutes and I've been really, I've only got to do that once more in the week and I've achieved my 75 minutes or more. But actually, if I'm physically inactive for the majority of my day, I could still be classed as a physically inactive person. So, and that still has additional health risks associated to it. So it's important to look at it from both angles. And social connection, so supporting people to develop and maintain healthy relationships, helping them understand toxic behaviour and providing them with social connection opportunities. Reduced social connection leads to health, behavioural and economic consequences, including increased risk of cardiometabolic and mental health conditions. So studies have associated, not loneliness with increased risk of death, increased risk of many different non-communicable diseases, and also loneliness as well can then increase risk of other harmful behaviours such as smoking and alcohol use. So this is some more information around children as well. So reporting bullying, and in this kind of online world that we have, it's often people are communicating via online methods, but making space for face-to-face communication as well. So sleep then. Lots of sleep problems in children. So the data for this is around children. I'll also present some data about adults as well. In terms of workplace and productivity, sleep has a massive impact on absenteeism and productivity at work. And the questions around sleep maybe is thought about in many contexts as a nice to have rather than like a real priority for public health. But maybe that needs to change to improve people's outputs. Lower socioeconomic status is generally associated with poor sleep, sleep disturbance, and shorter sleep duration. So we're seeing these social determinants of health being active across all of the pillars, really. So to try and improve sleep then, so adults should be getting between 7 and 9 hours of sleep per night. In order to try and help people improve quality of sleep, we want to be optimizing the sleep environment. So that might be making sure that you haven't got something really noisy outside or inside, trying to change those things that you can, optimizing light. So that's making sure that you've got a dark sleeping environment, no kind of fluorescent alarm clocks, but also making sure you get bright sunlight first thing in the morning. So your preparation for a good night's sleep starts at the beginning of your day, and what you do during your day can really make a difference as to whether you sleep well that night or not. So getting bright sunlight first thing in the morning can really help set your body clock with respect to that. So sleep efficacy is how much sleep for the time spent in bed. And so you might speak to someone, and I regularly have this conversation and with patients who say, oh, I sleep absolutely terribly. And I say, well, what time do you go to bed? Oh, well, I go to bed at like 10 o'clock. And what time do you get up? Oh, well, I normally sleep about 9 till about 9 in the morning, but my sleep is just absolutely terrible. So they're actually spending 11 hours in bed. And given that most adults need between 7 and 9 hours, as I said, if you're spending 11 in bed, you could reasonably expect to be awake for some of that time. So trying to make sure that actually you give yourself the right amount of sleep opportunity, not going to bed at midnight and expecting to get up at 5 a.m, that would be too short. But equally, spending too long in bed might increase the perception of poor sleep because you're spending time awake because you can't possibly be asleep for all of that time that you're spending in bed. There's a technique called CBT for insomnia, which I won't go into in depth, but it's kind of 4 main techniques. And there's an app called Sleepio that teaches them to patients. Optimizing your sleep schedule. So I talked about kind of giving yourself the right kind of length of time in bed, but also trying to keep that time consistent across the week. So I say to people, try not to have more than 1 hour difference between your weekday and weekend waking and going to bedtime. I think it's, you need to meet people where they're at. It would be completely unrealistic to say to people they have to go to bed at the same time and wake up at the same time throughout the week and the weekends, because people might have different social commitments. They might have to get up early for a job during the week and not want to do that at the weekends, and that's completely that's completely normal. And again, as I keep on repeating across the other pillars, you don't want to turn people off with your advice if they think, oh, there's no way I could be doing that at all. It's just and you need to meet people where they are. So I try to say an hour, and I'm flexible on that. But ultimately, if you're having going to bed at 9 o'clock during the week, and then at the weekend you're staying up till 1 in the morning, then you're going to create some sort of you're going to create like a jet lag type thing, and your sleep quality is not going to be as high. Finally, Z drugs. So this may be not all of you here are prescribers, so it may or may not be applicable. Z drugs, so sleeping tablets essentially, are useful in one situation only, and that is when someone has had some sort of acute stress that's caused them acute inability to sleep, and they need support to get back into a regular pattern with their sleep to avoid chronic insomnia becoming established. What we see with insomnia is that people might have some bad sleep and then they develop a sort of sleep anxiety, like they worry that they're not going to be able to sleep, and then that perpetuates the insomnia, and then you find chronic insomnia being established. So Z drugs, sleeping tablets, can be useful very, very short term to avoid that kind of situation if you have an acute stress that's affecting someone's sleep, but they should not be used long term at all. They will perpetuate the problem with insomnia, and ultimately you're then left with two problems, because you've got the insomnia problem and also then potentially the addiction problem. So yeah, avoidance of those in as far as possible. On other advice to improve sleep. So all the pillars are linked. Physical activity can improve sleep as well. So taking regular physical activity in the daytime. The caveat to that is don't do vigorous physical activity in the few hours before you hope to fall asleep. In terms of eating, the evidence is a little bit mixed around that. There are certain foods that are thought to boost melatonin production. Having a very heavy meal in the evening is thought to reduce the quality of sleep, but also equally you don't want to be going to sleep hungry. So you want to have your last meal a few hours before going to sleep. Not make it something really heavy, but try maybe having something quite satiating, so something that contains protein, complex carbohydrates, rather than having some sort of really high sugar food in the evening. Then minimizing harmful substances. So I'm going to focus here on smoking and alcohol, but obviously there are many more harmful substances and behaviours than that. Substance misuse frequently co-occurs with mental health difficulties. We're going to come to mental wellbeing in a minute, which is another pillar. Alcohol harm tends to be a higher burden in lower socioeconomic groups. So again, we're seeing this health inequality effect. And what I mean by that is that you might see people from a more affluent social group who drink at even higher levels than someone from a lower socioeconomic status background, but you see that the harm you see coming from the alcohol they consume tends to be higher if they're from a lower socioeconomic status background. So they tend to find that it worsens social problems a lot more. The same amount of alcohol will be worse for someone from a lower socioeconomic background compared to a higher socioeconomic background. Smoking is, as we saw in those tables at the beginning, the biggest preventable cause of illness and death. So supporting people to identify that they would like to stop smoking and signposting them to stop smoking services. So in these conversations, you can, when someone's talking about reduction or cessation of a harmful behaviour, then these are the kinds of things that can be helpful to talk around. So identifying perpetuating factors, so what's causing them to continue to smoke, identify any barriers to quitting, so I guess etiology would be what started it in the first place, perpetuating factors, what's keeping it going, help them to engage with smoking cessation services, and support with the psychology of behavioural change techniques. So motivational interviewing is quite often used in the context of smoking cessation, and that's kind of trying to elicit people's own feelings about the smoking and what they think is good about it, what they think is bad about it. Is there any kind of discrepancy between those things? So with smoking, someone might say something like, smoking helps me relax, but they also might say, smoking costs quite a lot of money and I've got quite a lot of financial stress at the moment. So they've got a sort of contradiction in terms there, in terms of it's both making them feel relaxed in the instant, but it's actually contributing to their level of stress long term, because it's contributing to the financial worries. So kind of helping them see that dissonance. Mental well-being. So I think this is the sixth pillar. I think we've gone through all of them now. So exploring the factors behind their stress, and signposting them for the types of things that might support them in managing their stress, be that actually solving the problem through legal advice, financial support, or housing advice, but also the kind of personal factors that might support them with having better mental well-being, whether that's kind of self-directed mindfulness, meditation or gratitude practices, education or advocacy, and also more kind of formal mental health support with something like CBT. And then, as I've been saying, you see all of these pillars being really interconnected. So are other lifestyle factors influencing their mental well-being? So a really key one here is, for example, alcohol. Alcohol is a depressant, so someone might be drinking alcohol because they feel really lonely, so that's social connectedness, but then that's causing them to drink alcohol, which is harmful substances, and then that has a knock-on depressive effect on them. So then you see all how those three pillars are interconnected, but thinking around other things that might be affecting their mental well-being. So another example there would be physical activity. So generally physical activity has a similar effect on mental well-being as a low-dose antidepressant. So if someone's not keen on antidepressants, then sort of talking to them about whether they'd be able to incorporate some sort of physical activity into their day, and that can have just as good an effect. If they do both, then the effect can be synergistic. So get an even better effect from doing both rather than one or the other. Again, food and sort of nutritional intake again can have a massive impact on mental well-being. So if someone's eating lots of high sugar foods, for example, you might see their blood sugar rising and falling rapidly throughout the day, and that can cause anxiety-like feelings in a person having large swings in blood sugar. So talking to them about incorporating more satiating foods and foods that are kind of keep the blood sugar steady through the day. So lean protein, vegetable and plant proteins, avoiding kind of high level of processed food, particularly those with high level of sugar, which tend to be hyperpalatable, promote binging, which again can be not very good for mental well-being. So yeah, lots of things that can be across the pillars that can be used to support mental well-being apart from within the pillar itself. So that is essentially how we define lifestyle medicine and all the things that we might be thinking about in a nutshell when we're thinking about lifestyle medicine. Just thinking about it now in terms of where it fits in with everything else. So I'll just, for the purposes of time, I'll just click through to the full picture. So essentially, you've got at one end of the spectrum the disease, at the other end of the spectrum you've got the environmental, political, socioeconomic factors that are much kind of higher upstream. Lifestyle medicine's here in the middle, about so it's sitting between it's kind of the thing that affects the upstream factors into the downstream illness. So here is where different kind of people or different roles can make a difference. And it's important to say that we're not saying lifestyle medicine is to the exclusion of these other things. You need to really intervene at all levels to have the best outcomes for people. So we're kind of working alongside those things. We think about, people with the skills and the tools and the knowledge to practice healthy behaviours, but then they need to be within an environment that permits that as well. You can have a permissive environment, but if they don't actually have any idea what kind of lifestyle they might be useful for them, then they may not follow it anyway. So the two kind of work hand in hand. Within the medical consultation, then you can think about when I'm approaching a patient, you might be thinking, do they need surgery? Are there medications that can manage this problem? And then lifestyle interventions kind of sit as a foundation below that, and they reduce the need for medication prescribing and surgery. They might be able to avoid it altogether, but ultimately it means that you have more options to offer to the patient. And that means that patients have choice, which is generally a good thing. And lifestyle medicine interventions tend to be very low risk, so it's sometimes something people are more comfortable with as a starting point. So there tends to be a little bit of confusion about what the difference between public health and lifestyle medicine and so on, and people think that it's full of weird and wonderful, wacky techniques, lots of supplements, lots of kind of analysing different aspects of your sweat or your saliva and making kind of assertions about that. It's not any of those things. So there are other types of medicine or types of techniques that use excessive testing, but lifestyle medicine just uses simple, proven screening tools. It's not complementary therapy, it's a fundamental part of mainstream healthcare. In terms of the difference with public health, so thinking back to that picture I showed you in the previous slide, public health tends to focus more upstream and think about the population as a whole, whereas lifestyle medicine focus on individuals and small groups. And it's really important that lifestyle medicine is not a way to blame people for, it's not saying you have got this health condition because you have led an unhealthy lifestyle. It's simply trying to understand the factors that are leading to the way someone's lifestyle currently is and helping them work out, are any of these things something that I could or want to modify? So we're going to go briefly now to a breakout room. We're going to put you into breakout rooms for non-clinical professionals and clinical professionals because your role might be slightly different within lifestyle medicine. So everything that I've talked about so far, just thinking about what you might be doing within your particular role, I'll give you 7 minutes to talk about this, and then I'll bring you back in. So if you could think about, I was going to do 10, but just from a time point of view, think about what could your role be in delivering lifestyle medicine, any areas you feel are outside the scope of your role, and then if you nominate a person to feedback afterwards, we can have a little bit of a discussion. I just wanted to briefly signpost you to the training needs analysis survey for NATH. So this needs to be completed before the 2nd of February. You can use the QR code on this slide to fill it in. So this is really talking about getting started. So a few techniques to use as you're having these kind of conversations around the 6 pillars of lifestyle medicine. So the first thing is use of screening tools. So this, for example, on the right is our lifestyle medicine screening questionnaire. You can also get a digital copy of this. Some people find it useful to send it out to people as a text message on ARRS before a consultation, and it can help you get a bit of a snapshot of where they're at in all of the pillars in order to work out where to focus your discussion, because as we know, we don't have loads of time in primary care often, so that can be really useful. In terms of having these conversations, we're going to focus now on 2 key skills, which do cross over, motivational interviewing and coaching conversations. I know some of you are health and wellbeing coaches, so I don't want to teach you to suck eggs, but I guess the stuff about coaching conversations is maybe more relevant for other clinicians, because any clinician can have coaching conversations in their role. They don't need to be doing formal health coaching in order to use those skills. So motivational interviewing, to start off with, it's a counselling approach using a client-centred style to elicit behaviour change by helping them explore and resolve ambivalence. And people are more likely to change their behaviour, particularly around alcohol or or illicit drug use and smoking, but in lots of different types of behaviours that people might want to change. Essentially, you're using a guiding style rather than being directive, clarifying their strengths and aspirations and evoking their own motivations for change, for them to make their own decision. So in terms of skills used within motivational interviewing then, tend to be using open questions. So that's questions that require more than a yes or no answer. And the idea about that is to encourage the client to talk about what's on their mind, which you might not otherwise know. And during that, they might say self-motivational statements, like they might say their reasons for wanting to quit smoking or take up physical activity, for example. So an example might be, how do you feel about your current level of physical activity? Rather than saying, do you exercise, for example. Affirmations, so that's statements recognising the client's awards, attempts, achievements or accomplishments. So that helps improve the client's sense of agency. So, for example, they might, they might be saying, "Oh, at the moment, I don't really go to the gym because I have to get home, put my kids to bed." And you might say something like, "So you really care a lot about your family?" I mean, that sounds very clunky, but I think as you practice this, you'll find ways to make these that seem less patronising, and basically it's your way of showing that the client you're listening, and you kind of are reinforcing the good things they're doing. Reflections then, so these are statements rather than questions. It's essentially you reflecting back what the client is saying to them, and it can show them that you're listening, essentially. And it also helps them, have the opportunity to correct any misconceptions about what you might have heard. Then finally, summaries. So that's like a longer reflection composed of more than one client statement. So you can use that to sort of signal a change in the conversational area. So moving to a different topic of conversation, you might summarize before you move on to close it. You might also do it in that situation that I talked about earlier. So, for example, you're talking about smoking cessation, and they've said that it's both a stress reliever and a source of stress. And you might, in your summary, put those two statements next to each other to see whether they would maybe pick up on that and think, "Oh, I'm maybe not making sense in my thinking around this." The same with this example around physical activity. Someone might be worried socially about going to an exercise class, but they might feel not very confident about going to an exercise class, but they might also see exercising regularly as a way to increase their self-confidence. So again, shows that you're listening. You move to a different topic or show discrepancies. So you can remember these as your ARRS skills. In terms of how you structure the conversation, there's no one-size-fits-all approach, and you can use these skills interchangeably in many different ways and orders in your practice. And what you'll find is you see experienced counsellors using kind of patient-led, counsellor-controlled approach. So using these skills flexibly throughout the consultation, the patient feels like they're in control and they're directing what you're talking about, but you're kind of making sure that the conversation stays within the remit of what you're trying to talk about. But start with some sort of structure might be helpful. This ask, advise, assist, arrange structure has been used a lot for motivational interviewing. So starting off by asking questions about what their thoughts about the lifestyle behaviour are, what's good and bad about it. You might then, with permission, offer some information of your own about the lifestyle that might kind of complement what they've said about it themselves. Then moving to assisting by evoking change talk. Scaling questions are really useful here. So you might say, if they're thinking about making a change, how important is it to you? If they're talking about a change that maybe is 3 out of 10 in terms of importance, then maybe speak to them about, is this something they really want to do? Are there other things that might be more important to them? Because actually, you might be discussing a lifestyle change that is not really that important to the patient, and at this moment it's not the right one to pursue. Asking them about their confidence levels. So if they say they're kind of 9 out of 10 confidence, you could say, "Oh, brilliant, what kind of makes you say that you're that confident?" And that can help elicit them saying what skills and resources they have to try and to make this change. Conversely, if they say, "Oh, I'm only 2 or 3 confident," you could then talk about things like what would increase your confidence, what would boost that number up to a 5 or a 6, and they might be able to identify the barriers that they're facing or the things that they're going to need to do in order to make this change effective. How ready are you to make this change? So discussing all of this with them helps them kind of strategize around how they're going to make the change, and then feeding this into a plan, so more overt strategies. You can use SMART goals in that context to make sure it's specific, achievable, measurable, relevant, and time bound. And I always like to say achievable and something that they want to do as well. So when time is short, which might often be the case in primary care, so this may be that you have a chronic disease review, that you've got a bit of time built in for discussing lifestyle, but it's still only a couple of minutes. So trying to think about how to do this in a time poor context is important. So just one question, like the really high payoff questions, can be useful. Giving them homework and following them up again, so getting them to go away and do some thinking and then come and discuss with them. What I'll quite often do is if someone comes to talk to me about weight loss, I'll ask them to keep a food diary and bring it back, and then we'll go through and try and identify the areas for them that they could be making a difference, because everybody will have different areas that they might be able to adjust their food if they want to do that. Thinking about it as a 3-hour consultation over 20 years, so you might see this person multiple times over the course of a number of years of looking after them, and in that time you can slowly move through these things, so they don't have to achieve it all at the same time. In terms of choosing the right questions, as I mentioned, these scaling questions are really useful. Other high payoff questions might be things like, what do you feel about your current level of exercise, or what do you feel about being on blood pressure medication? That might elicit them to start saying, well, I really want to get off the medication, I want to make these changes. Is there anything you think you've been thinking about changing to help your health? What stops you from making this change? That's the second question, really. What might you be able to do to improve this, and what could you do before we next meet to take this forward? In terms of, so identifying the right questions to ask, you can also save time by choosing the right patients. This won't be the right technique for everybody. Motivational interviewing, and so you don't want to waste your time doing motivational interviewing if it's not really the right thing for that person. Motivational interviewing is useful in the pre-contemplation and contemplation stages of change. So you've probably all seen this change circle before. Pre-contemplation is when someone is maybe not even aware of the need for change, and contemplation is maybe they are aware of the need for change, but they haven't particularly made a plan to do it. So it's that really early stage, that helping them resolve ambivalence and get forward in the cycle. And that's a really important thing, actually. It can move people forward to preparation, but if you see them 3 months later and they haven't actually gone into the action, or they're not in maintenance, that doesn't mean you failed. If you move someone from pre-contemplation to contemplation, you've moved them forward. So sometimes remembering that can help us not get disheartened if changing lifestyle takes a long time. So these are some statements that people might say in the different stages of the cycle of change to help you identify where they might be. So I'm not going to do this quiz because I think we'll run over the end if I do, but it was just a little quiz to help you identify where they are in the cycle of change and whether motivational interviewing would be useful. But to this end, we'll move on to coaching conversations. So as I alluded to before, they're not just for health coaches. Any clinician can incorporate coaching skills within their consultation. It's becoming more recognised and used across the NHS. Benefits that you might see from using a coaching approach during your consultation are increased engagement from the patients, implementing shared decision making between the patient and practitioner, and people are more likely to implement health behaviour change following a coaching conversation around behaviour change as compared to a more directive, you need to quit smoking type consultation. So key skills to be using in a coaching conversation: trying to establish rapport, developing an effective relationship between the practitioner and the patient, establishing an agenda for what you're going to talk about and what you're planning to achieve during that session. Listening is probably one of the most important, so listening effectively to what the person is communicating, and you can use some of those motivational interviewing skills to demonstrate that listening. Questioning again, so effective questioning can help raise awareness and facilitate motivation. So some of those questions that we discussed in the motivational interviewing section can be really effective here as well. Providing feedback, so sharing information or their own thoughts. So in the context of health coaching, because pure coaching often is you don't give any expertise whatsoever, but many of us are healthcare practitioners, and people come to us for our health expertise, so we have to have a way of integrating it. So you may well share information, but the important thing is it's in a non-directive way. So you might say, talk about the harms of smoking, or the strategies that can be useful for people who are trying to quit smoking, if that's what you're talking about. But you wouldn't be saying what you should do is this. It's down, we provide information, the patient makes the choice. And throughout the whole process, reflecting on your practice, being aware of yourself, being aware of what you've done and how that's impacted the patient, and what has come of it, so you can kind of work flexibly. As I said, I'm not going to get anyone practicing motivational interviewing or coaching today, but in all these skills will feel clunky at first. The important thing is that you practice. Just try one or two of these things out in your next consultation, see what the effect is, see, oh, that was really useful, or oh no, that bit wasn't for me, I'm not going to do that again, or I need to change that. But yeah, practicing it in your consultations and seeing what you get the best results from in terms of talking about behaviour change. So we've got a case to apply this to now. I've got two cases here. We'll just do the first one so that we make sure we finish on time for you. So Diana is a 42-year-old woman who presents with low mood. She's divorced and has 2 adult children. She's been sleeping poorly. She wakes at 3 a.m. and can't get back to sleep for around 2 hours, if at all. She would like to avoid antidepressants. So as we're a small group, I'll ask everybody to contribute at once, rather than going to the clinical professionals and the non-clinical professionals separately. But what else would you like to know about Diana? So feel free to unmute and shout out.
I'd like to know why she's not sleeping.
Yeah, and how might you go? Thank you for that. What might you, or how might you find that out?
Ask her why why does she think sleep's so poor? She might think it's poor sleep, but she's like you spoke about earlier, it might actually be that she's getting too much, not with 2 kids probably, but she might be getting too much sleep.
Yeah, exactly. So what does she, so there's loads of good stuff there, like working out what she actually means by poor sleep. And then the sort of why, the question I can't find useful is, what's going on when you're awake? Is it that your mind's right, or don't necessarily lead them, but is it that their mind is racing? Is it that they feel absolutely totally awake? Is it that they're experiencing that they need to go to the toilet in the middle of the night, and actually the real problem is a urinary problem? So yeah, like working out why it is and what that really means. And so definitely some more information around sleep. And Beatrice, you've got your hand up as well.
Yeah, I could ask her when it started, to get an idea of what the source of the issue might be.
Yeah, definitely. And then you can maybe, whether it's an emotional issue, maybe signposting towards some counselling, or if it's a practical issue, whether she needs support with, advice about housing support, those sorts of things, if it's some sort of practical situation. And just giving her the space to talk about it as well. And Chizumaga?
Yes, I might ask her to just talk me through her sleep environment, just to have an idea of what's happening regarding that.
Brilliant. Okay, so we've thought about quite a lot of stuff now. I'll give you a bit more. I think that's everybody who's got their hand up. Yeah. So on further questioning, Diana reveals that she's quite lonely following the divorce, and it's left her with some financial stresses. She drinks 3 to 4 glasses of wine nightly to shut out these feelings, and she doesn't like lying in bed awake, so she stays up watching TV till at least midnight, sometimes as late as 3. She has a dog who she walks daily. She used to enjoy cooking but cannot motivate herself to do this for just one person, and so often relies on ready meals. So so it's important, again, that we're not going to tell Diana what to do, but we might identify from this discussion some areas of the lifestyle where there might be gains to make. So which areas might you think would be worth talking to her about? And if anyone can suggest how they might ask about them, that would be brilliant. Jean, yeah?
Yeah, I might suggest referring her on to somebody to help with financial stresses. So maybe get a social prescriber involved, do a referral to one of the local voluntary schemes that might help her sort of finances out. Because we all know if finances are a stress, everything else follows suit, because it's all consuming. So try to help her tackle that first.
Thank you. And Chizimaga, your hand's still up. Is that still from before, or did you put it up again?
Sorry, that's from before.
That's okay. And Terence?
Yeah, I just think I'd open up a conversation just to find out what made her smile. You know, for example, in regards to cooking, if there's a preference, a motivation on, you know, who she may cook for, or when, what she likes to cook, and, you know, whether potentially as a long term she might want to be some kind of mentor and, you know, meet others with a similar interest and maybe a similar kind of thread in regards to she has a dog, so, you know, maybe she could be, you know, further down, have a conversation explaining how it feels when she walks the dog, and again, maybe meet like-minded people, sort of thing.
Yeah. Brilliant, thank you. So that would sort of give us some sort of mental well-being stress outlet, and it would also improve her social situation and social connectedness, and sort of coming back to Jean's suggestion again, that's going to improve mental well-being by working on the practical, and that obviously is the social determinants of health as well. Thank you. And Beatrice, I think, have you got your hand up again?
Yeah, I do. I definitely want to talk to her about her regimen regarding her sleep. That seems like quite a sort of almost like low-hanging fruit thing to change if she could. And so I was trying to encourage her around her watching TV. Is there something alternative you could do, like maybe reading, or even reading around cooking, maybe picking up a recipe book, one of her favorite ones, yeah, maybe just encouraging her around walking the dog as well, if that's something you can increase a bit more to sort of get her moving, get her out and about, and get out of the house a bit more.
Brilliant. So that's the physical activity side of things. Hopefully she's quite good with, because she does walk the dog daily, but making sure she is doing that, and can that be capitalised on both increasing physical activity and also using it as a social activity. So those are brilliant suggestions. Nobody's mentioned the alcohol. She's drinking every day, which is something that may not be a good thing for her long-term health, but specific to this presentation, alcohol is a depressant, and alcohol does significantly impact sleep as well. So you don't need to say, I'm not suggesting we say to her, you need to cut out all alcohol, but simple questions around, how do you feel about the alcohol? Do you notice any difference in your sleep when you drink alcohol compared to when you don't? She might say, do you know what, that's the most, the thing that I'm really relying on, and it really gets me through the day, the idea of having a glass of wine in the evening. And you might think right now is not the time to discuss that, and that's fine as well. But I think you can give people this information for them to decide what are their priorities to make a change. She's also relying a lot on ready meals. So a few people mentioned the cooking, trying to get her doing that again, because ready meals tend to be ultra processed, and ultra processed food consumption is associated with lower mood. So I think hopefully this has demonstrated, thank you all so much for your contributions to that case. Hopefully it's identified that actually all 6 of the lifestyle medicine pillars are potentially relevant to this case, and could be fruitful, but useful for discussion with the patient, for her to identify what then changes are her priority to go and make. So we've got loads of things that we could potentially talk to her about, and then she can select how she actually wants to go forward. The other case was around somebody with diabetes, but we'll leave that one for today so that we'll finish on time. So just to close then, we'll just say a couple of bits about the British Society of Lifestyle Medicine, which is my organisation. We were set up in 2016 by 2 GPs and a surgeon, and we now have more than 2,500 members. And our role is to promote lifestyle medicine and support clinicians and support healthcare professionals in acquiring the skills to help patients with behaviour change around the 6 pillars of lifestyle medicine. We spread the word globally, in fact, with education resources like the one I showed you earlier, the questionnaire, and then advocacy and influencing. We have our course, if what you've seen today has made you think you want to know more about lifestyle medicine, we have our course, the Core Accreditation in Lifestyle Medicine, and we have an annual conference which brings together everybody who's interested in this field, and we have our Learning Academy, which is the bit that I'm involved in, hence why I'm here today, but it's got lots of different CPD courses around different aspects of lifestyle medicine. So whereas the Core Accreditation is more of a comprehensive lifestyle medicine introduction, the Learning Academy's got courses around lots of different areas of lifestyle medicine. Lots of online resources. There's member-only resources on the website, but also lots and lots of resources for everybody, so you don't have to be a member to access them. We also have a journal that we publish in association with other global lifestyle medicine organisations, and particularly maybe of interest, we have lots of resources around group consultations, because we're often time poor in primary care and some of these things need longer. So group consultations, having sort of maybe 6 or 8 people in one consultation for up to an hour can be a really time effective way of delivering lifestyle medicine. So we offer lots of resources around how to do that. Lots of advocacy and influencing, so setting the stage for lifestyle medicine. We engage with policy and those kind of trying to make sure that as healthcare professionals we have the opportunity to do this. And as I said, we offer memberships if you want to kind of go deeper into this as well. So, general principles then for lifestyle medicine. Understand the evidence base behind improving people's lifestyle. So hopefully I've given you some useful information around the 6 pillars and the evidence for that. No, it's a set of powerful and low risk tools that you can use. So these are really low risk strategies, so people can try them without you worrying about the impact. Make sure you look after yourself whilst doing all of this. So medicine and healthcare can be draining, so make sure you're looking after yourself. The best lifestyle advice is given by, I've said it's not lifestyle advice, the best lifestyle support is given by people who are actively doing it themselves as well. So think about what you want to do in your own lifestyle. Have a strong understanding of the psychology of behaviour change, communicate effectively and compassionately, and know the available community resources. So we talked about in our discussion there quite a number of things that you could signpost within the community, so that's brilliant. In the consultation, make sure you're being person-centred, what matters to them. Effectively use the time you have, so hopefully some of the strategies that I've touched on today can be useful in a short consultation. Assess, don't guess, so don't assume what's what someone's issue is. Use evidence-based tools to gather the information, so our questionnaire can be helpful with that. Being effective using evidence-based techniques, and ensure that they are seen and supported again. Lifestyle medicine's for us too, as I said, so make sure you look after yourself. So these are what we were talking about today. Hopefully they've been delivered, and all that remains now is for me to say thank you very much for listening, and I'm happy to hang around if anyone's got any questions, or you can contact me on my email address here, and there's our Learning Academy website if you want any more information about our courses.